Our second speaker is Chang Xu, graduate student in the Department of Biostatistics, and he will be speaking on leveraging polygenic scores to study sex differences in blood pressure traits.
So hello everyone. So my topic will be leveraging the polygenic tool to study the sex differences in blood pressure traits. So just a few introductions. So blood pressure, also the BP traits, have well-defined complex genetic architecture with approximately 30 to 50% heritability, and also the hypertension, which is high BP. It is highly heritable and also leading risk factor globally for CVDs. So actually, the hypertension and CVDs, they have significant sex differences in prevalence, clinical presentation, the outcomes. And also, so previous treatment for the hypertension generally normalize the BP. They do not routinely account for the biological sexes. So because there are some sex differences in the BP traits, for example, the prevalence and also different hazard ratios based on different thresholds, and also the trajectory. So the hypothesis that the sex-specific association, genetic associations for BP can be identified through large-scale analysis, and also these findings can be leveraged to inform us the understanding of the potential clinical relevance of the sex differences of the influence of BP on CVDs. So based on this, we perform sex-stratified BP GWAS. So in our discovery study, we use the data from UKBiobank Bank with equal sample size for females and males, and also we perform replication analysis in MGI and GERA cohorts. So we identified approximately 1,400 previously reported loci and also 29 new BP-associated loci. So actually, we found that the females identified 1.8 times more loci compared to males, and also among those loci, 70% are unique in the sex-stratified results. So because we would like to study the clinical relevance of the blood pressure to for their relationship with other CVDs, so we leverage the top loci we identify in GWAS, and also we construct BP polygenic risk scores that we use 3 different analyses. So first of all, we using the MGI resources, we test the association of the BP GWAS, and then we try to predict the hypertension, and also we computed the proportion variance in BP explained by the given SNP. So for the association of BP GWAS with hypertension, we found that the SBP and DBP PGS were more strongly associated with hypertension than the PGS from pulse pressure. And also both males and females PGS for DBP and SBP was all significantly associated with hypertension in the both sexes. And the takeaway message from this analysis is that more significant associations of the PGS for SBP and DBP were derived from female GWAS compared to male. And also, the second one is the prediction of hypertension by blood pressure PGS. So we also perform this prediction using some adjusted covariance, and also with PGS only. And we found that for female-only analysis, they have slightly better performance compared to analysis based on male-only analysis, between some slightly difference between the ROC and IOC. And finally is the PVE. We found that actually females have larger genetic effects in females. So some of the significance and motivation. So we found that they do have sex differences in the BP, and also there are associations. And multiple CVDs traits show sex bias associations. So we are thinking about whether we can incorporate in the pleiotropic association between BP traits, hypertension, and the related CVD traits that can potentially benefit the study of sex differences. So recently we have a method that is incorporating additional traits and also the environmental correlation called MTPGS, which is recently published. So for some future work, probably using the MGI datasets, we can potentially predict genetic risk, and we can perform the in vitro risk stratification, and also to identify some potential risk factors and do some causal inference. We can study the relationship between BP and CVDs, and finally, we can consider using some subsequent analysis, for example, using TOS to identify some potential candidate genes. Yeah, so these are some acknowledgements. So special thanks to my advisor and my collaborators, and also the collaborators from MGI. Thanks.
One or two questions.
Very interesting.
Push the slide.
Very interesting talk. Thank you for presenting it.
Can you make a comment on how your phenotype for blood pressure or hypertension was defined? Was it ICD or diagnostic, or was it using vital signs?
So for UK Biobank, actually, we are directly using the data field, which is kind of like a special code in the UK Biobank data set. So actually, there are many previously conducted analyses using the UK Biobank resource because due to the large scale of the data sets, so we generally following their pipelines to define phenotypes.
So it's a phenotype for hypertension as defined by UK Biobank.
So for the hypertension, actually, I think just using so you extract the numerical value for the SVV, DBP, and PP, and then you define the threshold based on prior analysis to define the hypertension.
Is there any thought about doing subset or sensitivity analysis, either looking at a medication effect or specific sub-etiologies of the hypertension?
Yeah.
It would seem that the etiology would potentially explain some of the sex differences, or would be broader in overlap, that it would lead to mechanistic differences that could get washed out in the genetic signal.
Right. So I think just follow some previously conducted analysis. We adjust for BP medication, but I think definitely to include some other, just I mentioned in the future, we can use some other statistical methods to study the relationship between some specific medications, so other environmental factors that can contribute to the sex differences. Thanks for the question.
All right, thank you very much.